So how does wound care work in an outpatient setting?
Well, in a typical outpatient setting, even if you're doing orthopedics or you're doing sports medicine, you're going to come across wound care. You're going to have that rotator cuff incision that dehisces. You're going to have that ACL, that total knee that's going to have sutures coming backing through. So there's really no avoiding it. And that's what I teach the students as well. Is you may think gross, stinky, and nasty are the first thoughts that come to your head when you think wound care. But even if you're into sports, you've got to be able to handle some situations without hitting the panic button and calling a physician every time you see a suture backing out. And so I think to kind of sidetrack there, I think wound care is in all of our, we just don't think about it as much. But when you're focusing in on it, like many of our clinics in this area we do, it has several different components to it. First of all is sales and marketing. It's not your typical folks you're working with in your team. We have endocrinologists, podiatrists, vascular surgeons, plastic surgeons. That's not your typical referral sources or your teammates with typical physical therapy. So we build a good team with those folks, and we have a back and forth referral relationship. So we may get someone referred to us from a family practice or nurse practitioner, and after the assessment, we come to the conclusion very quickly they need to see a vascular surgeon. So we're the one that's turning around and referring them for that, and then back and forth. And that is an interesting part. I think our team, when it comes to our other allied professionals and our other professionals that we work with, is a much broader net than when I see the orthopedic side, which usually is just orthopedist, maybe your primary care physician worked in that team. When it gets to wound care, a lot of these patients are diabetics. You're going to have your endocrinologist. You've got to get that glucose under control for them to heal. And the diabetic usually has impaired blood flow, so now you've got to get your vascular surgeon in there and work with them. If you end up needing grafting, that may be your plastic surgeon getting involved. So there's a lot of components and a lot of teamwork in the wound care side. In the outpatient wound care clinic, your typical patients are going to be walking in off the street are venous and diabetic ulcers. Most people, when they think wound care, they think probably what they saw in a hospital when they were doing their internship of large pressure ulcers. In the outpatient setting, we see very little of that. It's mostly the patient is probably in your orthopedic setting every day. You just didn't ask them to take their shoe off and notice that they had this nice little hole on the bottom of their foot. The American Diabetic Association usually asks at any appointment that you ask the patient to take their shoes and socks off where you see their feet. And in that, they believe that we will reduce a significant amount of amputations if we catch these problems sooner. So I would have the viewers keep that in mind. If you're seeing diabetics, regardless of what they're coming to see you for, ask them about their daily foot care, especially if they've already developed neuropathy. Venous ulcers, those patients, especially after knee replacements, hip replacements, if they're having a lot of swelling below the knee, they can develop more venous issues. And then, as I mentioned, dehisced surgical. We see very few cat bites, dog bites, human bites, but those are in there, gunshot wounds occasionally, that type of thing. But 80% of patients that walk in an outpatient wound care center are venous stasis ulcers. And those are usually contributed by age, obesity, and some other factors. If you have more than one child, you're at higher risk. And so as the population is aging, we're going to see a lot more venous insufficiency problems, a lot more ulcers. And then where does the therapist kind of plug in there besides just education? As I mentioned, debridement. In many states, the Practice Act limits who can perform debridement. So your physicians generally can, your podiatrists generally can, but in many states, nurses are unable to. So if you think about the physicians, how many surgeons really want to work on a wound? Probably not. And so if you as a physical therapist, your Practice Act allows you to do debridement, then that opens an avenue for your treatment. And debridement is one of the primary keys of getting someone to heal. So we use an acronym called DIME, and D is for debridement, I is for inflammation or infection, M is for the wound margins, and E is for the edge of the wound, the edge effect. But D is where we come in with the ability to debride these wounds, to get them cleaner, to get them the biofilm off of them, and allow these wounds to heal better. And then as a therapist, we're also making that dressing choice. When we talk about dressings, I won't get too far in the weeds, but just a quick help any person that's changing a Band-Aid. Drainage drives decision-making. So if you have a heavily draining wound, you need something like a foam that's going to absorb a lot of drainage. If you're having minimal drainage, then you could probably get away with a little Band-Aid. And then the second thing to look at is, do you think there's an increased bacterial burden? And so you have all wounds are contaminated with bacteria. Some wounds become colonized, meaning that the bacteria is now replicating and growing. And then some wounds progress to infection, which means they're doing harm to the host and they're multiplying. So if you're concerned about any bacterial burden, then we have things like nanocrystalline silver, which kills over 150 different types of bacteria on contact, as well as MRSA and VRE that we see in the news. It also is antifungal and has an anti-inflammatory property to it. So it's a very interesting product that's been out since about the 90s. And we have things like cadaxmer iodine, which is a non-toxic form that we can use and to help get rid of bacteria. So the old days of rinsing it every minute with hydrogen peroxide or alcohol or Dakin solution, which is nothing more than household Clorox, household bleach, can be harmful to healthy tissue. So I'd encourage folks not to use that. So good hygiene. So in the outpatient setting, in our outpatient setting, we also use technicians. So the technician often brings the patient back, removes the old bandage, does good hygiene around the wound, soap, wash it with soap and water. If they're going back under compression, applying moisturizing cream so they're not going to be itching between visits, and then hands it over to the therapist to assess, make decision to debride or not debride, choose the dressing, choose whether it needs to be offloaded, such in a diabetic, or compression wrapped in a venous ulcer. And then oftentimes these patients are seen 1 to 2 times a week, and they are long haulers. So your average venous ulcer takes about 12 weeks to heal. So from a reimbursement and a business model, you've got a nice business model to go by, because these people are going to be around. Unfortunately, diabetic and venous ulcers have a very high reoccurrence rate. So that it's a very good chance in 6 months or a year or two that patient will be back in to see you. Even with good education, they often have a reoccurring problem. So reimbursement is good. Debridement charges and compression wraps actually with Medicare went up significantly in the past few years, where everything else has creeping down or holding still, or even possibly getting another 9% cut next year. So it is a nice market if anyone enjoys doing that type of work.